everybody. Welcome to GI. Alright, so on the board, so let's talk about whatever we need to know about GI for the board. I'm going to try to cover everything that we need to on one board. Okay, so first off, let's start with, this is what the hepatobiliary tree looks like. You got the liver, you got the gallbladder, you got your cystic duct, your left and right hepatic ducts that join to form common hepatic duct, right? This is your cystic duct, and then this is going to come joined to your pancreatic duct here, right, to form your common bile duct, which is going to drain into the second part of the duodenum, right? Okay, so let's start off with the first organ that we're going to mess with. Okay, let's take the pancreas. Okay, we see this a lot in real life, but also you're going to see it in the clinical STEM for the questions too. So people can get something we call as acute pancreatitis. Okay, acute pancreatitis. Okay, when would you suspect somebody of having acute pancreatitis? What would they present with? Abdominal pain, which is going to be radiating to the back, right? So how do you diagnose acute pancreatitis?
2 out of 3 criteria.
You have a 2 out of 3 criteria. What are the 2 out of the 3 criteria? So number 1 is going to be pain, right? The classic pain with radiation to the back is going to be present. Number 2 is going to be,
Elevated lipase.
so you'll check for lipase or amylase, and that needs to be
3 times the
greater than 3 times the upper limit of normal. Okay? And number 3 is going to be imaging. Does it have to be a CT scan? No, it doesn't have to be a CT. Could it be MRI? Could it be CT? It could be ultrasound? Yes. Right? It could be any form of imaging. But most of the time what we go for is going to be a CT scan. Right? So you need 2 out of the 3 to diagnose acute pancreatitis. So if somebody comes with acute abdominal pain, that seems very classic for acute pancreatitis, and you get a lipase or amylase, that's elevated. Are you going to get a CT at time of admission?
No.
Are you going to bug the ER to say, hey, get me a CT scan before I can admit? No, why not? Because you don't need it. 2 out of 3 is good enough. So it doesn't mean every single patient you admit to acute pancreatitis must get a CT scan is a false assumption. You don't. Okay? So it's 2 out of the 3, you say it's acute pancreatitis, right? Okay. Now, what causes acute pancreatitis?
Alcohol use.
Okay, so what are the most number 1 causes? Yes. Gallstones, and then alcohol. Okay, these are the 2 most important causes that you need to know about when it comes to acute pancreatitis. Okay, then what else do we have? Okay, increased triglycerides. What else? Autoimmune. Good.
Drugs.
Okay.
Medication.
Trauma. Medication. Drugs. Which drugs?
Valproic acid.
Okay. Valproic acid. What else?
Protease.
Acid. Protease inhibitors.
GLP-1.
Okay. GLP-1s. Good. Everybody keep taking the drug more and more. What else? What diuretics can do it? Hydrochlorothiazide and Lasix can do it too. Okay, furosemide can do it as well, right? So there's lots of drugs out there that can actually genuinely do it. This is just a handful they like to question about, but if you really look at the literature, pretty much most drugs can cause acute pancreatitis. Okay, what else?
Post-ERCP.
Post-ERCP, very good.
Antivirals.
Huh?
Antiviral medication.
Protease inhibitor.
Like protease inhibitors, right? We wrote
Yes.
already. Here. What else?
Scorpion stings.
Scorpion bites, yes, our favorite. Okay. Triglycerides is a combination of what? 3 free fatty acids plus glycerol 3-phosphate. Okay, that's the biochemistry behind it. So if you have a lot of triglycerides and they come into your biliary tree, what's going to happen? The bile acid is going to break it up and release a lot of free fatty acids. And the free fatty acids is irritative to your biliary tree. And as a result, it's going to cause inflammation, blockage, and acute pancreatitis. So typically, it's going to be greater than 1000. It can also be NS. So you could use any isotonic fluid. LR or NS is fine, right? But before, the idea was LR actually had better mortality benefit when they got it. But the last GI, the update that came basically said no, they both have the same effect, so you're okay. The only time you should not use LR on the context of acute pancreatitis is when you have hypercalcemia, because LR has a lot of calcium, right? Alright, so fluids. Now how much fluid will you give?
A lot.
About 1.5 ml per kilogram of body weight. Okay, that's how much you're going to give. For how long are you going to go aggressive fluid hydration? 24 hours, first day. So only for 24 hours do you actually want to give aggressive hydration. If there is necrosis, right? Previously we said if there was necrosis greater than 30%, that automatically bought you antibiotics for this patient. But is that true anymore? No. Presence of necrosis alone is not enough for antibiotics. You need necrosis plus signs of infection. Okay, you can have necrosis but no fever, no white count, no antibiotics. So what you're looking for is necrosis plus signs of infection. Okay. All right. Now, when would you have to do imaging? When would you have to do imaging in the sense of a CT scan? If you did admit a patient with acute pancreatitis and you didn't do a CT, when would you do a CT scan? The way you're going to check for prognosis is based on what scoring systems? Ranson and Apache. Those are the two for prognostication, right? Now, a couple of signs can dictate that the patient is going to have a bad outcome. What is that? Elevated hematocrit, meaning the patient is having a lot of hemoconcentration is an important sign, right? Now, your patient can also have, you can go into ARDS because of acute pancreatitis as well, right? Now, that's your PaO2 to FiO2 ratio, right? So, remember your Apache and your Ranson is more for prognosis, not for acute decision making. That's an important thing to know. Acutely, when you want to decide where a patient actually goes for acute pancreatitis, are you going to treat them as outpatient, inpatient, or ICU is dependent on what? There's a scoring system known as modified Marshall scoring system. Okay. Again, I don't think you need to know that part. Just the reason I bring this up is because sometimes they'll say, okay, where do you want to admit this patient? What is it going to be determined on? Never pick Apache or Ranson. Those are two for prognostication. Okay. All right. So that's acute pancreatitis. Now, let's track back for a second. We said the most common cause somebody has acute pancreatitis is gallstones. So let's track back here to the gallbladder, right? If somebody's got gallstones in your gallbladder, what do you call this? Cholelithiasis. Okay. Now, is having gallstones in your gallbladder a good thing? No, it is not a good thing. We all agree on that. Right? So let's talk about all the possible bad things that can happen. Sometimes one little stone trickles all the way down, comes to your common bile duct and blocks this, and we call this cholelithiasis, which is the one that's going to cause acute pancreatitis. What is going to be present on your CMP that's going to tell you, hey, think of choledoco here. You'll have a cholestatic pattern, right? Your bilirubin, total bili, and basically your conjugated bilirubin should be elevated. Right? What else would go up? More than that, cholestatic pattern is determined on ALP. That is more important. Yes, you can have elevated AST and ALT as well, but predominantly what you're looking for is elevation of bilirubin and ALP. That tells you it's a cholestatic pattern. Okay? And whenever you have a cholestatic pattern, what is your next step? What do you need to do next? Yes, so you typically, if you do an ultrasound to see, because when you have a cholestatic pattern, you do an ultrasound on it, pretty much everybody. Start both least invasive and the cheapest. Always pick that. Never pick anything more expensive. So ultrasound first. When you do ultrasound, you'll see gallstones. Can you see ductal dilation?
Yes.
You can. If you saw ductal dilation on ultrasound, you really don't need an MRCP. You could really call GI to go and fix the problem. But if it is not conclusive, then you would do a MRCP. So ultrasound first, then you can do ultrasound first, then you can do MRCP. Okay? When you do the MRCP, you'll see if there's a stone and the ducts are dilated, gives you a much better idea. What else does the MRCP tell you? It can tell you stone ductal dilation, but it can also look for masses. MRI is a superior imaging. So it can give you much better precision as to what is probably obstructing. It's not always a stone. It could be a stricture. It could be an ampullary mass. It could be something external compressing it. So MRI is going to give you a lot more information. Alright, now when it comes to acute pancreatitis, I said antibiotics. What is the best antibiotic to use for pancreatic penetration? It is carbapenems. Okay, pharmacy is not going to like this, but carbapenems. Imipenem, meropenem, they are the ones who actually have better penetration for pancreas. Okay? Okay, so if you have a stone in the gallbladder,